Welcome and good morning. Thank you everyone for joining us for today's webinar, Your Guide to CalPERS Health Regions. I'm your host, David Takearts, and I'm the Stakeholder Strategy Manager for CalPERS there on the left. And joining me today is Sherry Little, CalPERS Chief of Healthcare Policy and Research, and Gary McCullum, a retired CalPERS Health Actuary that we love just so much we just can't let him go no matter how hard he tries to stay retired. So we got him in here for today's session. Before we jump into the material, let me just go over a few quick housekeeping notes for you. First off, got some good news for everybody. Today's webinar will be closer to 45 minutes, not at the full hour. So you just got 15 minutes of your day back, so we're off to a good start already. Secondly, everyone's favorite question, can we get a copy of the slides? The answer is yes, we will send that out. But I will say in advance that the slides that we're covering today are really more of supportive visuals that help to tell the story, but they don't have huge chunks of data or text that a person could easily read through on their own and get the whole gist. That's what we have our subject matter experts on the line for us to do for us. So what we're going to do is actually record this entire webinar with all the audio, and we'll send out the link to that recording shortly. So that would be within a couple of days. And we'll also post this to our website, calpers.ca.gov, and to our CalPERS YouTube channel. So we'll send you out that link. And then, yes, we'll also send the slides too. But I think you'll see pretty quickly that they're really more supportive, and the real heart of the content is in the words that are being spoken. Okay, so speaking of the spoken word, today's webinar is going to be a one-way audio street, so you can hear us, but we won't be able to hear you. I think that'd be just a little bit overwhelming since we have several hundred folks on the line with us, but we do have a way for you to engage with us. If you look to, I believe it should be on the bottom right of your screen, you should see a chat box. Go ahead and type in any questions that you have at any time during the webinar, and we'll be able to see that here in the room, and then I think we'll have a little bit of time at the end, and we'll field as many of those questions as we can. So go ahead and shoot those in there. I think, again, that will still be one way. I don't think that you'll be seeing each other's questions. Not positive on that, but you'll be able to send that to us, and we'll be able to see it here in the room. Okay. All right, enough housekeeping. Let's go ahead and dive into it. So here is our rough agenda for today's webinar discussion. So first thing we'll be talking about is why do we have health regions at all? This will be a look back at how the current health regions were developed, sort of a history and background. We'll look at what's the impact of regions on employers and what's the relationship between regions and the premiums for the healthcare. And finally, we'll talk about the next steps in the regions setting process and how you and your agency can stay informed and be involved. And then, like I said, we'll wrap up with some Q&A at the end. All right, so that's our rough agenda for the day. Before I turn it over to our experts to get into the nitty-gritty, there are just a few things I want to cover, sort of a level setting in layman's terms so that we're all speaking the same language here. First off, when we're talking about costs today, and that's going to be a big piece of this, we're talking about costs, we are talking specifically about the cost of health care, not the cost of living. There are many areas in California where the cost of living is very high, but relatively speaking, the cost of healthcare is actually fairly low. And we'll talk more about why that is. But just keep in mind that for the purposes of this discussion, when we're talking about costs, we're not talking about things like rents and mortgages and cost of living, et cetera. It's really specifically about the cost for employees and their dependents to get healthcare. All right, so that's one big piece. Number two, our conversation today applies to basic plans only, not to Medicare plans. Notice I didn't say current or active employees versus retired employees because there are a lot of retirees who have not yet aged into Medicare plans. So the distinction is really basic plans and Medicare plans. Just to be clear, we are for sure talking about basic non-Medicare plans only today. And the third thing I wanted to toss out before we get into it is that this regions discussion only applies to public agency and school employers. Okay, so the cities, the counties, the special districts, and the schools that contract with CalPERS for healthcare benefits. If your employer is technically the state of California, or you're a retiree of the state of California, then this does not apply to you. We're going to take a look at why that is too, by the way, but for now, just so you know, when we're talking about employers here, we're specifically referring to public agencies and schools in California. All right. All right, so enough from me. Without further ado, let me turn it over to Sherry Little, our Chief of Healthcare Policy and Research. Sherry?
Thank you, David. I think you did a great job of setting the stage. So we're really excited to talk to you today about regions. It's been some time since we've had a comprehensive assessment on regions and the objectives why we initially established them. Regions are a complex topic and they directly impact you and the premiums that your agencies and your employees are paying. So we want you to be able to take away a better understanding of what they are and their impact on the health program. So everyone's heard about CalPERS in terms of pension and investment programs, but health is the third pillar in that. So I'd like to begin by just kind of giving you some background and history on the health program. CalPERS is the largest purchaser of public health benefits in California and only second largest in the nation to the federal government, which also purchases Medicare benefits. We have about 1.4 million total covered lives, and that includes both active and retired employees, annuitants, and their families. We provide health plans for the state and also California State University System employees and their dependents, and we serve 1,200 public agencies and schools who contract with us to provide their healthcare coverage to their employees. Last year, that spend equated roughly $9.3 billion. So of that, public agencies and school employers make up 41% of our program, which is roughly 600,000 total covered lives. Our employers are a huge part of that membership we serve, and we take that responsibility seriously and to heart, which is why we're having this discussion today. And of course, the state is our largest employer, but we don't have to compete in the market to retain its business. State employees and retirees will always get their health benefits through CalPERS. We do, however, have to compete to retain our current employers and also win new ones. When we add total covered lives into our program, we gain leverage, and that gives us the ability to better negotiate rates with health plans and also strengthen our leadership position in the marketplace. So I want to talk about the criteria for success in assessing and developing regions based on the three principles. We have to remain competitive in the market. Regions have to be able to provide the greatest benefit for the greatest number of people that we serve. And we must be PEMCA compliant at all times. So PEMCA, for those of you who don't know, is the Public Employees Medical and Hospital Care Act, and that governs the CalPERS health program. And it enables us to provide quality health benefits to your employees while we're able to reduce the financial risk to both CalPERS and to the public agencies. Contracting agencies and school premium rates are based on the region where they're located. So you may ask, what is a region? A region is a grouping of counties and zip codes. It's a boundary of geographic areas where the costs are comparable. In this case, regions are a grouping of counties that have similar costs for health care within an area. I want to reemphasize from David's opening remarks that we frequently hear from our members that they equate their premium rates with the cost of living in their area. And these are two very different things. With premiums and this topic of regions, we're talking about the cost of just healthcare in an area. And we'll talk more about that and what that means. So maybe it would be helpful by giving you an example of regions and premiums in the life of a school administrative employee. If we take a business manager of a school district in Ventura County, this member has PERS Choice PPO and today a monthly premium of $1,613. If we move that an individual to San Luis Obispo County, also a health employer, the monthly premium changes to $1,817 for the exact same plan. So if you do the math, that's $204 difference in a monthly premium. So it begs the question, why the difference? Agencies are located in different regions and they're roughly 120 miles apart, and although both of them are near the coast, they have different healthcare costs. So they're in different regions with different premium rates. Going back to why CalPERS established regions in the first place. Before 2005, we didn't have regions. Each plan had the same premium rate regardless of where a member lived within the state. In some areas, such as in LA, employers and the members were paying premiums that were really in excess of market rate. And that's just because healthcare costs in Southern California are lower. And Gary's going to talk about this a little more as we progress in this. Regions were created to address a real problem for our health program. Between 2003 and 2004, we saw approximately 37,000 total covered lives, mostly in CalPERS, that were at risk of leaving. That included more than 70 public agencies, and that would have increased our premium cost for everyone in the program. So the risk of a large exodus from public agencies was very real to us. So this prompted the health team to take some action. We looked at regional pricing as the way we could maybe regain our competitive edge and bring agencies and stability back into the program. We face fierce competition in the market. Agencies and schools can purchase their health benefits from anywhere, from sources other than CalPERS, whether it's brokers, health benefit trusts, or others. And we've seen a lot of competitors just swoop in and offer below market rates to win new employers. In 2003 and 2004, our competitors blanketed Southern California, quoting rates that were between 14 and 24% below what we were able to offer for comparable benefit plans. Of course, from our vantage point, we know that they're offering lower rates to win the business, only to have large increases in subsequent years. But this proved to be a really tough message to counter to our agencies, who were paying more than market rate for premiums. So we decided to take some action. CalPERS sponsored legislation to gain the ability to offer benefit plans to public agency at rates that were different than the statewide rate. In 2004, we contracted with Milliman, an outside actuarial firm, to perform an analysis of our costs, population, and to work with us to explore possible options for regional pricing. The goal was to retain and gain agencies and schools by offering premium rates more aligned with market rates. We analyzed population density of the state and performed actuarial analysis that compared the average regional cost of care by county to the average cost of each plan. Our resulting data showed where plans' costs were higher or lower than the average statewide cost. So Milliman developed a methodology to account for regional cost differences and took into consideration the demographics, disease burden, provider practice patterns, and reimbursement levels. We then took a look at the location, relative cost, and the number of members and grouped them into counties into 4 regions. The 4 regions first adopted by the board were the Bay Area / Sacramento, other Northern, Los Angeles, and other Southern. From 2005 to 2009, we had 4 regions. Since 2009, the board carved out Sacramento, which includes Sacramento, El Dorado, Placer, and Yolo counties, to create a new region, and that's how we get to the 5 we have today. One of the questions we get asked about regions frequently is about geographic sounding names like the Bay Area or Los Angeles, instead of assigning numerical designations or colors or some other nomenclature. Go figure. I've been here for 2 years, I can say on my own behalf, and have asked that question, and we're still trying to figure out why it is that we decided to run that route as part of our overall recommendation was that when we created them in 2004. When the Sacramento region was created, and it left surrounding areas such as San Joaquin, Nevada, and Solano in the Bay Area region. It's one of the biggest complaints we hear, and we get it. So as part of what we're going to do is we're going to evaluate potentially changing the names of the region. We're exploring a new naming convention as part of the effort this year. So overall, regions have been successful for us in accomplishing their goal. We didn't experience the mass exodus. We were allowed to remain competitive with premiums that are reflective of the market. And over the past decade, I'm very happy to say that our total public agency population has grown by 26%, and in Los Angeles alone by 60%. As of today, we have a 99% retention rate with our agencies and schools. So now I'd like to turn over the webinar to Gary McCollum to kind of walk you through some of the details about costs and what's on the table for discussion.
Okay, good morning, everyone. Thank you, Sherry. I'm Gary McCollum, and as you heard at the beginning of this, I recently retired. But when I had the opportunity to come back and work on this Regions project, I couldn't pass it up. So I'm very excited to be here and to tell you a little bit about what we're going to do. But first, I want to remind you, I want to reiterate, I want to say it one more time because we can't say it enough. This discussion on regions and regional premiums applies only to the basic plan rates. Our Medicare rates do not vary by regions. Also, CalPERS is a not-for-profit organization, and our health plan rate proposals must reflect true cost of care in any region. Now, two of the questions we frequently get asked are, one, how are the regional premiums developed? And two, why is the state rate lower in some cases than the regional rate? So let's start with the state rate. The state of California, as you heard, has one rate. That's because the state is one employer, and although there are state employees in every county, there's one pay scale, there's the same classifications, and there's the same benefit structure for all state employees. So there is a single premium rate regardless of where state employees reside. Now, during the rate development process each year, we begin by establishing an overall base rate that uses the size of the entire CalPERS health risk pool of basic members. That's almost 1.2 million people. And we use that to negotiate the best possible rate for each plan. Each health plan's state rate is based on their population of members in all the regions combined. Now, the number of members in regions varies, and the number of counties covered by each health plan also varies. And it varies from the PPO plans, which cover all 58 counties, to only one county, San Diego, for Sharp Health Plan. So, regional rates are then calculated by taking the state rate and multiplying by a regional factor. So now, it's time for you to ask, well, what is a regional factor? Well, the answer is, it's a measure of the average cost of healthcare in that region in relation to the average cost of healthcare in the whole state. So let me illustrate this with a simple example. Let's assume there are just two regions, Region A and Region B, and there's just one member in each region. So if the state rate was calculated at $100 per member, we would collect $200 in total, $100 from each member. Now, let's say that the cost of healthcare in the B region is less expensive than the state. Let's say it's $80 per person. Well, the regional factor for the agency and school employers then would be 0.8, which is 80 divided by the $100 state cost. On the other hand, let's say the cost of care is more expensive in Region A at $120 per person. So their factor is 120 divided by 100, which is 1.2. Now, notice that the $80 collected in the B region plus the $120 collected in the A region equals the same $200 that we would have collected if we had just charged the state premium for both members. Okay, let's pause a moment and go into some basics, or what we'll call Healthcare 101. So put your thinking caps on and let's go back to school. So there are differences in the cost of healthcare in Northern California versus Southern California. That's just a fact. And we often get asked why. So now let me repeat again, because we can't repeat this enough either, that the cost of care in an area is not the same as the cost of living in an area. For example, A Bay Area worker might move to Manteca in order to find affordable housing, but that doesn't necessarily mean that the cost of healthcare will be correspondingly lower. So to get back to the question of why health premiums are more in the North than in the South, well, there are several reasons, and a 2017 report by the Center for Health Policy at Brookings, I think, says it best. The report noted that Northern California is dominated by a few large healthcare systems. Also, insurers have less leverage when negotiating in regions with fewer hospitals and large medical groups. In addition, labor costs for healthcare workers are higher in the North. Northern California doctors also have more fee-for-service agreements with insurers. Now, this means what it says. The doctor gets paid a fee for providing a service. Providers make claims based on the number of procedures carried out for a patient over a period of time. Fee-for-service can create an uncertain financial climate for providers because finances depend on the number of services rendered. Additionally, the projected amount per patient will vary widely because some patients require little or even no care, while others might need extensive treatments. In other words, fee-for-service is a volume-based system that can become costly and cumbersome for both the provider and the patient. Now, in the North, there's also a higher level of what's called provider concentration. That's doctors concentrated into a smaller number of networks and groups, and that lowers competition, and it results in rates being 30 to 40% higher in Northern California versus Southern California. Now, healthcare in Southern California, on the other hand, has more smaller, independent systems and more hospitals. There's much less concentration of providers. And the insurers' agreements with doctors have more capitation, which is a set price per person per month. Now, with capitation, the providers have a contract to receive a flat monthly payment for every patient that's enrolled. Providers are reimbursed for every patient within a certain time period, whether or not they receive care, and regardless of the cost of the treatment. So capitation is intended to create a system that fosters efficiency and cost control while providing incentives for better health care. When compared to fee-for-service, capitation is the more financially certain method of reimbursement. And finally, essentially, there's just more competition in the market. And that's really the reason that cost of healthcare is less in Southern California compared to the North. Now, I gave you that example of 2 members in just 2 regions, but I think you can see that if you increase the number of regions and you increase the number of members in each region, the calculations can become quite complicated. So let's get back to regions. Should should CalPERS have fewer or more regions? Well, there are pros and cons with both. As you know, we currently have 5 regions. Covered California has 19 regions. CMS with the Medicare program has 27 regions. So is there a magic number? Probably not. Earlier in the webinar, we talked about why a single statewide region doesn't work for retaining and attracting agencies and schools. So let's eliminate a single region as a possibility. And now let's talk about the pros and cons of more versus fewer regions. With fewer regions, there's more covered lives in each region, and that makes costs less volatile year to year. It also makes administration less costly and burdensome. However, it is likely that there will be a larger differential in the average cost within any sub-region of the region you're talking about. And that will cause some entities to argue that their cost isn't really reflective of the cost of the region that they've been put into. So more regions means average costs that are more reflective of the region. However, more regions means less covered lives in any area, and that means potentially more cost volatility from year to year. And it also means more expense because there is an administrative burden to CalPERS and to the State Controller's Office. And you know that more administration just drives up the cost, which is ultimately reflected in your premium. So, over the next few months, all options will be on the table for consideration. Our job is to create regional scenarios for analysis, looking at the cost of healthcare in different combinations, and then we'll bring that information before our board. We will be looking at whether we should consider splitting counties in some way. For example, Los Angeles County has most of its population in the southern part of the county. So should we split LA into two regions? Covered California currently splits LA County into two regions. Also, do regions need to be contiguous? Or could we have a region made up, for example, of some northern counties and some central California counties? So we will run models for these scenarios that we create. We'll look at the regional costs. We'll analyze them for consistency, such as what is the lowest cost in that region and what is the highest cost within that region, and what's the difference between those two, and is that difference palatable or is it too big? We'll be mindful of the market so that the regional cost is not out of line with what agencies in the region would pay if they decided to go elsewhere for their health care. And finally, we'll also look at the naming conventions and we'll consider eliminating geographic sounding names. So that concludes my presentation. I'll now turn it back over to David.
Thanks, Gary. Beautiful work. That's why we can't let you drift off quietly into retirement. We need your expertise. And thank you, Sherry, as well, for your excellent commentary on this. So let's do a quick recap here, and then we'll get into some questions that have come through the chat function. So what did we talk about here? So first off, we explored how the 5 regions that we have today were established over the course of the last 15 years and what precipitated that. We talked about the need for CalPERS to remain competitive on pricing with private sector competitors while still adhering to the strict standards of care and administration in the PEMCA laws. And we talked about the need to do the best possible good for the highest number of people. That's what keeps and attracts employers to the CalPERS program, which in turn ups our purchasing power and therefore keeps your prices down. We talked about how the main factor in setting regions is not necessarily geography, but really the cost of care in that area. That's the number one driver, and how that's led to the current 5 regions that we have. And we highlighted the significant difference in healthcare costs and really how healthcare is done between Northern and Southern California, and how that's the main barrier to simply having a single region like we do for the state of California agencies right now. And lastly, we talked about what to expect in terms of what we're bringing to the CalPERS board over the next few months for their consideration. So quick kind of like sub-recap on that. In September, we'll be presenting the analytics of the costs as well as the results of some surveys that we've done leading up to this. So that's in September. Then there's no meeting in October because we're doing our annual conference then, and we hope you can attend that. In November, we'll have the modeling completed based on the data that we presented back in September, and we'll bring those regional scenarios to the board. So that's really what Gary was talking about the most there at the end was we're going to model some different sets of options and take a look at what that would mean in terms of costs and impacts and availability to our employers and members. And then lastly, we're going to take the input from those meetings from our employers, from our stakeholders, from the board, of course, and then bring back a final proposal in December of 2018 for a decision. And any changes or decisions that were made at that point would take effect in the 2020 year. Okay, so a decision in December of 18 wouldn't then go into effect that very next month. There'll be a year to implement and administer. All right, terrific. So we do have a little bit of time here. So let's go ahead and field some of your questions. So I've got the easy job here. I'm just going to ask questions of Sherry and Gary and then put them on the spot. and we'll ask them to opine on some of these issues. All right, so first question here. Okay, so speaking of the modeling scenarios, do we have any scenarios like in mind or anything that we're already leaning towards, or anything that staff is intrigued by that we're going to be kind of advocating for specifically to the board?
Thanks. That's a great question, David. And the answer to that would be that we're revisiting this because it's time to look at the data and the analytics. And that's really what we're doing. So we haven't jumped to any conclusions in advance of that. And this is fact finding at this point in time. So as you mentioned, in November, we're going to bring some options forward based on the data and the analytics, and then go from there, and the surveys that we receive, stakeholder surveys.
Great, thank you. Okay, next question here. How does this discussion of fee-for-service and capitation that you were talking about, Gary, how does this apply to Kaiser? Is there anything particular about that health plan that is different in that conversation?
Well, Kaiser is a different animal than the other health plans. Kaiser is what's called a staff model, where the physicians are employed directly by the health plan, or actually the Kaiser Permanente group, and they also own their own hospitals. So they are a different animal than the other health plans, which go out and negotiate contracts between provider groups and hospitals.
Terrific. So another question that came in, is it possible to allow members to travel to another region to reduce the cost of some procedures? Would this help to lower the costs in the higher cost regions if they see they're losing business unless they charge less? Could this kind of help the overall equation? How does that work?
An individual has the option of choosing their residence or their place of work as the place that's put down for their health care. So if they happen to live in a region, in one region, and work in a different region, they have the option of choosing which region they would prefer to have their premiums based on. But as far as traveling to another region, that's a whole different animal. That's actually called, there's a name for traveling to another area for care, and at the moment our board does not have that as one of the options.
So to piggyback on that, it's not site specific or facility specific. It's really based on one of two things: your residence, as Gary mentioned, where you work, where you live.
Great, thank you. Okay. Why can't CalPERS make it so that higher cost regions are capped out at the state rate?
Well, we could, but you have to realize that the insurer, as I said in my presentation, the insurer or the health plan negotiates with us for a rate for their whole membership in total. And then the factors are used to split out the regional rates based on the region's cost of care. If you were to take the more expensive costs and cap them at a rate less than what they should be, you're just moving costs to some other portion of the population. So that could be done, but it's not done, and it would be subsidizing costs in the more expensive region at the expense of those costs in another region.
Right, and that would kind of lead back to where we were originally, where we had agencies who say, listen, this is a free market, and unlike state agencies that are a captive market, a DMV in Los Angeles County can't simply say, we're going to contract with external health exchanges for benefits now. No, they are a captive employee of the part of the state system. This would kind of lead back to that same situation where large chunks of employers are leaving or threatening to leave, and that would compromise the cost for everybody.
That's correct.
Okay, terrific. Okay. All right, so here's an interesting one. So, Gary, you were talking a lot about we saw a pretty clear picture of the difference in healthcare costs and administration, just kind of like how healthcare works in Northern versus Southern California. Like, what is CalPERS doing to lower those rates? Just kind of like a general, but like what are we doing? What can be done? Like what is on the table in terms of that northern versus southern bifurcation?
Well, we constantly work with our health plan partners to negotiate the best rates possible, and we work with them for them to get the best rates that they can with the providers. As the presentation said, one of the issues is the amount of capitation versus fee-for-service in the South versus the North. And we're constantly looking for ways to improve the amount of capitation that's available in the North, which would help control costs in the North.
Which is why we also have a rate negotiation period of time between January and June every year. We go back through and evaluate where the health plans are and what we can do to help them leverage the most cost-effective and best quality of care for our members.
Okay, this next question I think is coming from one of our retired folks who's on the line. So this question, we talked earlier about how employees you can kind of choose whether or not you're going to have your residence or maybe your employer, if those happen to be in different regions. Can you talk about how that works with retirees?
Well, retirees unfortunately don't have a place of work, so they have just one residence.
Okay, so
to choose from.
So they wouldn't be able to say, okay, well, my last place of work.
No, they do not have that option.
Okay, another question that came in. Would it significantly impact the cost of care if a particular large county within a region, so pick XYZ county within a large region, expanded the size and services at some of its hospitals, increased the number of medical providers, and had many of its employees living within relatively short distance to Kaiser facilities? So I think kind of like the point here is like, what's the level of increase in overall providers and the availability of care in a region? What would be enough to tip it into a different region or cost tier?
You can't really answer that question because, well, first of all, we have, as we said, 1.2 million members. So any one particular county is somewhat dwarfed in terms of their impact on the whole program. But if a county could get more hospitals, more competition within that county, that would help in some manner, but I can't put a number on it.
Right, and it probably wouldn't be an immediate, we're not monitoring, okay, we're at 99% capacity, they got one more hospital, now rate change. It would probably be a slow moving thing that would be picked up in our cyclical review of these regions like we're doing right now, but it would take a number of years in the future before it moved that tipping point.
Well, not necessarily, but if we were aware that the costs in a region were going down, we would put that into our calculations for the next rate cycle that's being calculated. So it wouldn't take years for it to show up in the data, but we would have to be aware of it.
Okay.
So to that point, one of the things we do with our health plans is that we have quarterly business reviews, and we kind of walk through the trends that they're seeing, and that gives us the opportunity to see this kind of thing in advance and negotiate during the rate cycle.
Thank you. Okay, so question, what about smaller counties with smaller populations? Why is there so much volatility with the premiums?
Well, the volatility comes from the fact that they have a small population. I think I can give you an example that might illustrate that. Let's use an expensive disease, cancer, and I don't know the exact number, but let's, for this example, say that cancer generally occurs in 1 out of 10,000 patients. So if a county or a region has 10,000 or more members, you can expect 1 cancer case on average. But if the county only has 1,000 members and they get a cancer case, well, the cost of that treatment impacts just the 1,000-member average cost significantly more than it would if it was occurring in a county with 10,000 members. And that's why the cost volatility can change. You could have a small number of members. One year they have one cancer, next year they have no cancer patients. The following year, let's say they have 2 or 3 diabetics, or they have one severe auto accident that can run up costs into the hundreds of thousands of dollars. And the smaller the population, the more impact these expensive cases have on their average cost.
Terrific. Okay, here's a challenging one. This is a tough one, and we may not be able to answer this right here because it's specific to individual counties. You may have to do some research, but here's one for you, for the folks. Okay, Riverside and San Bernardino counties have similar healthcare costs and service issues, claims this questioner, but are considered part of 2 different CalPERS regions. Can you talk a little bit about issues like that where you have really directly kind of adjacent regions that seem to at least have very similar healthcare costs, at least from the local level? Like, how was the decision made to split them into different regions?
Okay, that's exactly why we're looking at this regions project. At the time, back in 2004, 2005, the decision was made to put San Bernardino County with Los Angeles County and Ventura County to create the Los Angeles region. And Riverside County was put in with the other Southern California counties to create the other Southern region. We're taking a look at it now to see if that split is still appropriate, or whether we should consider grouping the counties in a different way. That's really, that question comes to the heart of why we're doing this.
Great. Terrific. Thank you, Gary. Okay, so we have time for one last question here. Let's see, kind of going through. I do have some questions that really they're healthcare related, but they're not really specific to rates, such as like the number of dependents on plans and billing issues. So I'd love to be able to address those kind of offline with the folks. So if you want to shoot those, I actually can't see your email on here. So if you wanted to shoot us an email to the website that you see on your monitor, we can address those ones that aren't specific to rates necessarily. But I'm going through for one last one here. Okay, these are pretty specific situations. Okay, thank you for whoever asked this one. Will there be other stakeholder outreach other than the surveys? Okay, yes. So over the next couple of weeks, we're going to be meeting with the associations that represent the largest groups of employers, of retirees, and also of the labor unions and member associations. So we'll be having individual meetings with representatives from that. We've asked those kind of like associations to reach out to their most engaged members within their organizations and bring them to these meetings. So we're going to have some in-person meetings, and we're going to discuss a lot of what we talked about today and then get some inputs. But I do want to caution that the main driver of this is going to be analytics. We do want stakeholder input. That's going to be important, but the primary driver is going to be the realities of the cost of care and the realities of healthcare, the way that it's administered and delivered in California. So that's going to be a major message that we share with the stakeholders. So those conversations, those meetings are happening in late August, early September, and then it'll be really part of our currently existing stakeholder outreach efforts. So every month before board meetings, Thursday before, we have our stakeholder engagement briefing. Many of you probably participate in that, or at least receive are on the distribution for that. So we'll be talking about this topic at the September, November, and December stakeholder engagement briefing. And so there'll be plenty of opportunities for engagement through that. This is a big, I can say with all sincerity, this is a huge issue for CalPERS, and we know it's a huge issue for our employers, for our members, and even for our retirees, especially the basic plan retirees. So we're going to do a preponderance of outreach on this, and you will have every opportunity to be informed and engaged. Okay, so it looks like we've run out of time as I continue to rattle on there a little bit. Thank you all for your participation. We want to thank you for your time, and thank you, as always, for the work that you do to help provide health benefits to California's public employees. Thank you, and have a good day. Goodbye.